I'm Dr. Cheville, a surgical pathologist here at the Mayo Clinic.
My name is George Vasmazis. I'm a genomicist by training and bioinformatician. With Dr. Cheville, we co-direct a program that is trying to find biomarkers for different cancers.
And we're here today to discuss our paper, Large Chromosomal Rearrangements Yield Biomarkers to Distinguish Low Risk from High Risk Prostate Cancer. As a pathologist, my job is to make the diagnosis of prostate cancer, usually on prostate needle biopsy specimens. Prostate cancer is graded by the Gleason score. Prostate cancer has a number of different patterns ranging from indolent to aggressive, and most prostate cancers are composed of more than one pattern. And Dr. Gleason, who described the Gleason score, indicated that we need to indicate the two most common patterns and add them together to get the Gleason score. Most men have Gleason score 6, which is an indolent or behaves well, and many of these men don't need treatment. Once you have pattern 4 or Gleason score 7 or higher, the outcome tends to be worse. So in this study, we looked at various Gleason patterns and Gleason scores to look at the association of chromosomal changes with Gleason pattern and Gleason score. The purpose of this study was to identify men that have Gleason score 6 on biopsy that harbor a higher grade cancer that may have been missed at the time of needle biopsy. And so the overall design and goal of the whole project was to identify markers that could predict upgrading on a patient with Gleason 6 cancer to say, hey, you may have a higher grade cancer and need closer surveillance, or may even opt for earlier surgery or radiation.
Luckily, at the time we started this project, there were really disruptive technologies that they were coming to our hands here in the clinic, particularly the next generation sequencing technologies. And we had developed a whole genome technique. I will talk about that a little bit later, with which we can see rearrangements across the whole genome of tumor cells. Here at Mayo Clinic, we have a very large repository of both frozen cases from the frozen section of practice, and also in paraffin, which have outcome information. And we were able to design these 3 different steps carefully.
Yeah, so we took a group of specimens from, as Dr. Vasmazis mentioned, over 100 patients, and we looked at Gleason, focused on the Gleason score and Gleason patterns in these cancers. So we took a group of patients that had a very small Gleason score 6 cancer that would be expected to have a very good outcome. We took larger Gleason 6 tumors, also likely to have good outcome. And then we took that intermediate group, the Gleason score 7, that had a pattern 4 that would indicate they might have a worse outcome. And then we had the higher risk group, the 8, Gleason score 8 and higher. And what was important is that intermediate group, the Gleason score 7 that had a pattern 3 and a pattern 4. And we needed to understand the relationship when those 2 patterns occurred together, because that seemed to be the step where the prognosis became worse. And so we isolated cell populations by laser capture microdissection for each of these groups, and we separately collected Gleason pattern 3 that was next to Gleason pattern 4 and analyzed those separately. And that was important because we wanted to determine if the alterations associated with outcome, the changes associated with aggressive behavior, were seen in the 3 that was next to the 4. And not seen in the 3 that was all by itself in a Gleason score 6 cancer. And that would provide the necessary hypothesis that if you sampled a Gleason score 7 cancer and only sampled the pattern 3 and found alterations that were abnormal, that could indicate the presence of a pattern 4. If the pattern 3 in a Gleason 7 cancer looked more like a Gleason 3 in a Gleason 6 cancer, then that would give us no information in regards to upgrading of higher grade cancer in the prostate gland.
Yeah, particularly the selection of the cases, the careful selection of the cases was very important. Most people, when they're trying to find biomarkers, many times they look at extremes, the very indolent to the very aggressive, And in those cases, they find many changes that they are statistically significant, but only a few of them will be important. With our careful design to have the 3s next to the 4s and making sure the 3s had the abnormality too, we were able to select a much smaller set of biomarkers, which was the right set to select for validation on the forward steps. We were able to laser capture microdissect about 100 different samples, and we were able to amplify the DNA from this small numbers of cells for each sample, running through the next generation sequencing protocols. And of course, what happens, you get large amounts of data. So we developed the algorithms to analyze these data sets and look for abnormalities like gains and deletions that they seem to have a predictive value between the indolent and significant disease. Also, because we were finding these areas, but these areas did have large numbers of genes involved, we looked at the literature in those genes and tried to find genes that they had somehow relationship to prostate cancer. One of the most predictive genes was P10, but interestingly, it was hit in many different ways. Sometimes with junctions, sometimes with large deletions, sometimes with small deletions. So that was very important because we thought that the typical tests for P10 wouldn't be able to capture the complexity of how P10 could be deleted or could be malfunctioning. But with our technologies, we were able to develop a sophisticated FISH test so that we can capture those abnormalities for that particular gene. And once we developed those FISH tests, we validated these new assays in an independent group. When you do the discovery and you do laser capture microdissection, you do not discriminate in what cells you are collecting other than the Gleason pattern. But when the FISH test was applied, Dr. Seville was able to look at areas, confined areas, where those markers showed some signal. And in that way, the visual plus the FISH test was actually more predictive than the bulk experiments we did with laser capture microdissection. And that was a pleasant surprise for us.
It was interesting, and the point is that for the LCM collection, you select only a small area of a larger tumor for analysis, and when we analyze the FISH, that allows us to look at the entire section. So we find populations of P10 deleted or other markers were abnormal that we wouldn't have selected by the laser capture microdissection step.
So we were pretty enthused by that the validation experiment results, and the next step was to take this to paraffin biopsies, where Dr. Seville will explain the result of that experiment.
So we took the panels that we selected from the first step, and as Dr. Vatsmansas mentioned, we selected or constructed FISH probes based on the sequencing information. And that's, as Dr. Vatsmansas also mentioned, critical for P10 because of the variation we identified in the P10 abnormality. And we were able to develop a probe strategy that captured all those P10 abnormalities. And I think in the area of prostate cancer, that's important. Tumors at other sites also have P10 deletions, but they may not be the same pattern or same diversity as we see in prostate cancer. So this was a probe strategy built specifically on our sequencing data. We then took a set of 100 independent paraffin-embedded sections of radical prostatectomy specimens, took the index tumor, again, the various groups we looked at the discovery set, insignificant Gleason 6, large volume Gleason 6, Gleason pattern 7 and 8 and higher, and performed our panel of FISH probes, and identified that these probes, other than one, could predict upgrading in the prostate gland. That is that the Gleason pattern 3 associated with Gleason pattern 4 showed the abnormalities within the Gleason pattern 4 and could predict a higher Gleason score in the prostate gland. So the next step is and to work on and to push forward is taking the needle biopsy specimens and applying the same set of fish probes to these biopsy specimens. And you can envision a man with Gleason score 6 prostate cancer is deciding whether they want to pursue active surveillance or treatment. We could apply these probes, and if these probes are all show that these genes are all normal, that would be reassuring to the patient that there isn't a higher grade cancer in the prostate gland. However, if there are abnormalities such as P10 deletion in this Gleason score 6 cancer, that might be an indication that there is a higher grade cancer present, and patients should have closer active surveillance or again may even consider treatment.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.